Hello, my name is Preethi Gopinath. I'm a consultant histopathologist in Harlow and Essex in the UK, and I've been asked by the college to speak to you about data sets in histopathological reporting of cancers. So if we think about the learning outcomes for today, first of all, to understand what the data sets are, to understand what the elements of data sets are, and to understand the application of data sets in daily practice, which I think is the most important thing. And most of my content will be examples of data sets and where you can use them in day-to-day practice. So I'm a consultant histopathologist in a district general hospital, so I don't work in a teaching hospital. And so my access to molecular testing and specialist rare immunohistochemistry is probably similar to yourselves in terms of access. So we report breast, colonic cancers, lung cancers, thyroid, and those are the majority of cancers that we do. We don't do any major gynae or urological resections in our department. So, but in essence, I'm going to talk to you about the general principles about data sets and how you can use them to improve your consistency of reporting, which I think is the most important aspect of this. What are data sets? They're published by the Royal College of Pathologists, provide a textual guidance and educational information related to that particular tumour site. And they also provide very useful reporting proformas, which you can use and adapt to your own practice to whatever suits you in your local network and department. They can be found on the RCPath website under datasets. A very quick Google search will get you there, and they're accessible to anyone via that website. The only ones that aren't accessible directly to non-members of the college are the datasets that are under consultation, for which you need to log in to be able to put your comments in and access the document. So what are datasets? They provide information about how to grade and stage cancers in an accurate and consistent way. So that's the most important thing, is about consistency, making sure that everyone within your department or area is reporting and staging cancers consistently using the same guidance. And that way the clinicians are able to manage patients more predictably. They have a set layout or plan for their patients according to the staging and grade, and if that's done in a consistent way using the same guideline, then that means that we can those results are more reliable. The other thing is that the data sets are based on international standards, so depending on the tumor site, these can be WHO, AJCC, TNM, obviously, and all of these international standards are used where applicable. There are some where the RCPath have got their own position on certain things. For example, in breast, there's slight differences between the RCPath guidelines and the AJCC guidelines in terms of various measurements. But so when we're practicing and using the RCPath guidelines, we use what they have recommended. But in general, there is a compliance and agreement with the international standards, and these provide prognostic information, most importantly, because they're based on the evidence, they're based on the long-term survival data, and then that's why we use them for all our cancer reporting. They can provide high clinical standards and also guide the management for specific clinical circumstances. What are the limitations of data sets? Well, they can't anticipate every pathological specimen and clinical scenario. So whilst they say, cover the common types of specimen in that tumor site, they can't predict everything. And so there does need to be some occasional variation from the recommended practice to maximize the benefit for the patient. So these are guidelines. I think the general theme is that when they're audited, that that the core data items should be used in over 90% of your reports, and the core data items really should be 100%, but acknowledge that there will be some variation from recommended practice because of a particularly unusual specimen, but that's what we aim for. So part of these core data items, and I'll talk about those in more detail, but the core data items are really there's the kind of essential bits of information that you put in your report. And the reason why they've been deemed to be core is because there's robust evidence in terms of their prognostic value. The clinicians need them for management and prognosis and staging. They also meet the international standards of boards for health and social care, the ISB standards. And as I said, 90% of cancer resection should record a full set of core data items. And we also have non-core data items which vary from tumor site. So I'll talk in general principles, but obviously specific tumor sites have got different non-core and core data items. That can be according to local clinical or research requirements. So certain trials may require certain bits of information that isn't in the core data items. That doesn't stop you from putting it into your reports. That's perfectly acceptable, but the important thing is that it should be in addition to the core data items. And we have the Cancer Outcomes and Services dataset, which is the COSD database, national data collection on cancers. And that is all hospitals in the UK have to collect that data and put it into the database. And it's a very important source of information in terms of healthcare planning and knowing what the cancer outcomes are nationally, which is also obviously very important from a health economics and epidemiology point of view as well. So the core data items are designed around the Cancer Outcome Services data set, because the core data items are the information that's required for that. So that makes it a bit easier, because if you have all of that information in your report, it makes it very easy for anyone to put that information into the database without too much problem. Evidence base. So the evidence base for data sets obviously varies according to the tumor site, but in general principle, it's providing an update on international tumor grading, staging, and classification systems. So if the WHO is updated, for example, if the TNM AJCC is updated, then that might trigger then an RCPath review. And usually the revision cycle is 3 years. However, there are a few current exceptions to that, which the revisions are in progress that have gone beyond the 3-year mark. But in general, it tends to be 3 years that there's a review, and the review may be major or minor. So if it's a minor review, there may not be that many changes or any changes significant to practice, but there will still be an updated version. The evidence bases or systematic reviews, so medical literature databases, PubMed, for example, and any levels of evidence which provide a good practice point, so high level of evidence. And the levels of evidence are provided in each of the data sets in the appendix, so you can see that. They try and correlate with the National Institute for Clinical Excellence. So if there is a specific change in the NICE guidelines for a particular tumor site, then they will try and correlate with that in the document. And if there's any major revision, then there will be a member consultation where all members of the college will be invited to comment on a major revision of a data set. And there are various groups where the data sets have to be approved by, so the clinical effectiveness group, lay governance group, and working group on cancer services. And these groups all also peer review the data sets as well. So the elements of a data set, so you have the introduction, as with any, and that's pretty standard in all the data sets, will have similar text. the target users, so who are the people who are going to use the document and what the health benefits are of using it. What any changes to the previous edition, if applicable. Obviously, if it's a new data set, brand new one, I mean, there are very few like that, but if it was a brand new one, that wouldn't be applicable. And then goes on to the specifics of the data set. So the clinical information required on the request form, which is really, really helpful because you can put that to your clinicians. You can say, actually, in the data set, this is a national standard or international standard that we want to follow in our department. These are the recommendations of what should be put on a request form. And then you can also audit that. So you can audit against the RCPath standards to say that actually the clinicians need to provide this information and they're not providing it. And that can be really powerful to then present back to your clinicians and then get them to hopefully improve their practice in terms of clinical information, because we all know that there can be you know, a paucity of that at times, and this kind of audit or use of these documents can really help to pass that message on. So the preparation of the specimen before dissection, so that's talking about opening it appropriately, and any particular margins or inking you want to do before opening. That is obviously specific to the tumour site, so certain data sets won't have that information if it's not applicable. And then there's specimen handling and block dissection, block selection. That's obviously the macroscopy or grossing, and that's an important part, and certainly we use that in our department to guide our standard operating procedures for specimen dissection, and all our staff that do specimen dissection follow these documents. Then in the macroscopy and microscopy, there will be core data items. Obviously, in the macroscopy, certain tumour sites, for example, colorectal, have very specific core data items in the macroscopies, such as the plane of excision and distance from margin, maximum tumour diameter, those kind of things, which are macroscopy core data items in colorectal, but other tumour sites may not have that many macroscopy core data items and mainly focus on the microscopy. So it depends on the tumour site. There are also non-core data items, as I mentioned, and then pathological staging according to the TNM, and it's usually the 8th edition that we're using. But again, we're guided by the data set, and whatever version the TNM is correlated to that data set, and that's the current version, that's what we use. But importantly, in your report, you should always mention the edition of the TNM that you're using, and the detail for each specimen type. So they have sections on the biopsy reporting, resection reporting, frozen section if it's applicable. And so it's a very nice document that you can go through and go to the particular section that you need. And we have them on our computers, opened up, you know, ready to go and ready to refer to whenever we have a case. So it's one of those quick reference documents that's really helpful. You know, you can do a quick word search in the document to find a specific section that you want to see. The criteria for audit of its data set, so they give you the recommended standards, so you can then say, okay, I want to audit our reporting practice for this particular standard, and then, you know, in the document it will say, okay, this many reports should contain this information. And so that's really helpful because you can do a very quick audit of your cases, particularly once you've implemented, let's say, a reporting pro forma based on the Royal College pro formas that they suggest. You could then audit your reporting after 6 months, a year, and see how the department has incorporated this. What's the consistency of reporting? Is it all being used to the appropriate standards? So that helps to increase the standards of your reporting across the board, so that everyone is doing a similar thing, and then that way it makes it much easier for the clinicians as well. And then you have the references, you know, relevant to the specific tumour type, tumour site. And then the appendices are very helpful. They're obviously varied, but generally include reporting pro formas in different formats. I'll go into that later. So the core data items, these are the examples of the types of things. As I said, you might have macroscopic core data items according to tumour site, microscopic, so that would include tumour type, differentiation, grade, PT stage if applicable, for example, in colorectal, resection margins, lymph node status. These are just examples. Obviously, each tumour site will have specific core data items for microscopy that you'd refer to, depending on the case that you're reporting. Separate abnormalities, response to preoperative therapy. These are all things that might be part of your of the data set that you're using. The non-core data items, these are varied, they can be quite extensive, but the important thing is that they're not essential to include in the report. So really it's a question of also focusing your time and effort on the report, because if you're spending all your time adding lots of non-core data items, you've got to ask yourself, what am I achieving by adding all this information? Is it of any benefit to the local clinical team or the research trial that you're involved in? That's absolutely fine then to include it. But if actually your clinicians are not going to really be using this information, then essentially, you're spending all this time doing excessive measurements or interpretation, when actually you should just be focusing on what the core data items are, making sure those are included in all your reports. And then if the clinical team or your department feel actually you'd like to record this bit of information out of interest, and also in potentially in the future to then look at a group of cases or prospectively that you want to record, that's absolutely fine, whatever you agree to. But you've got to think about what your efficiencies of time and make use of that appropriately. So the appendices can be varied, but generally have the TNM classification appropriate to that tumour site, the SNOMED and SNOMED CT codes for T and M, and there's some procedure codes in some of the data sets. And those can be helpful, again, to make sure that you're using the up-to-date SNOMED codes. And then the reporting pro formas for the different types of specimen. And they have it in template form, so one like a checklist where you can essentially adapt that and then tick off or enter the relevant bits of information into it, and that can be your report. Or like us, we've adapted all of those core data items and put them into our own information management system so that we can create our reports using those synoptic reporting lists. So there isn't a format where if you wanted to have a drop down options where you select a particular option, you can also design it like that, because it has a list format with all the possible options that it could have. So that's also very helpful. And the levels of evidence are also there for you, and then the compliance standards for good quality clinical guidelines, and that's on every data set. So these are just some examples of various data sets that I've just taken from this, obviously from the breast data set. Obviously that's my I'm lead for breast pathology in my department, so this is an area particularly that I refer to quite commonly. This is a wide local excision specimen. You can see there's lovely illustrations here which really show you how the kind of process of taking blocks in a standardized way. And if you have this, and this is not the only option, so they have a coronal slicing option, they have cruciates margins taking, so there's lots of different demonstrations of different approaches to cut up. So don't think it's that you must do it in a particular way. Most of the data sets do give you options. They are very bit written in an open way that doesn't restrict you too much, which is really great. So you don't have to say do this in a specific way, but obviously these are the ways that are recommended in order to get the information to provide your core data items in your reporting. And so you can see there that, this is the way that you could suggest to be inked different colors, and then, how to slice it, and then in terms of embedding and what you're going to sample. And so that this is very helpful. This is another demonstration, so coronal slicing with calcifications. And so if you had calcifications in the wide local, you'd want to make sure that you've, sampled it extensively, looking at that and looking at the calcifications. And orientation with cruise ship margins. So that's a nice demonstration. And then you've got mastectomy, which again, lovely illustrations here, which show the coronal slicing method. So this is the method that we use in our department. I know a lot of people use the anteroposterior slicing, which is absolutely fine. And this is the demonstration of how it might be sliced and kept in the after fixation. And this is an example of how you might map out a tumor with the relevant margins and how you might block that. So this is really, really helpful. This is an example of how a central lymph node should be sliced. So there is another diagram at what surfaces should be embedded. So making sure it's opposing surfaces of each slice embedded, so you don't have the kind of immediately adjacent slices embedded. So you examine more surface area of the lymph node that way. So that's really helpful as well. And then this is another example of a different data set. So you've got upper GI, esophagectomy, and example of pinning out of the specimen for fixation, and then after it's been cut, how it might look. With a combination of longitudinal and horizontal slices. We use a lot of photography and put those photos into our reports, which the clinicians find really helpful. But yeah, so that's an example, and this is another. These are all images taken from the various different data sets. So just to show you, how useful these can be. They've got the SEWIT classification and TNM classification, how that correlates to, because obviously from a clinical point of view as well, this is helpful. Yeah, so this is a nice diagram that kind of is a quick reference for that. This is an endoscopic mucosal resection and how that might be pinned out and then bread sliced at 2 mm intervals. And so these are just examples of how you might handle these types of specimens. So obviously not all might be applicable to where you're working, and so you use whatever is useful to you in this. And this is an example of how a reporting pro forma might look. So as I say, you can take this original document and then fill it out and make it electronic, and that's also possible, or you can adapt it and use it in your own systems. But importantly, it gives you all of the kind of core data items in here. So if you use this, you know that you're recording all the right information. This is an example from the colorectal data set, which is quite extensive, particularly with the macroscopy aspect. Talks about and which I think is really important, because it is one of the hardest areas, certainly for when you're training, to cutting up accurately colorectal specimens, identify the peritoneal reflection, talking about circumferential resection margin, bare area, etc. And so these the pictures in the data set are really helpful for learning about that, and also making sure that everyone is interpreting things in the same way. So this is a nice example of the tumor site and the classification of the position of the rectal tumors. And then this is an image of the plane of excision. So what a mesorectal plane of excision looks like, with that shiny fascial covering over the circumferential resection margin. And there are various different pictures with, the muscularis exposed, etc. So that can be really good, again, for consistency, making sure everyone's interpreting the appearances in the same way. And so it's an example of muscularis propria with defects. And so this is really, really helpful in daily practice. And this is an image showing about the TNM of colorectal tumors, and how the distance between beyond the muscularis propria is really important for colorectal reporting in terms of prognosis, and talking about tumor deposits as well. And in addition to that, you also have the microscopy section, which again can be quite extensive and depends on the data set. But for example, this is the colorectal data sets where it's showing about the distance to the margin and how diathermy artifact and how you might measure the distance to the tumor when you've got a lot of necrosis, inflammation, etc. So that this can be a helpful thing. And these are written by very experienced authors who are experts in their field. And so these are the kinds of scenarios and difficulties that they come across on a daily basis with their expert opinion practice. And so it really is helpful for us to benefit from their knowledge and experience, and lots of the scenarios that are discussed or the difficulties discussed in these data sets are real ones, and I find them very helpful to refer to. So the microscopy pro forma might look like this. So this is again the colorectal one, and you would have the polypoid tumors, the polyp tumors, the PT1s. These would be like this. The resections, the T2, T3, and then the number of nodes, number of tumor deposits, any neoadjuvant therapy, what the response is, and obviously this depends on the tumor site as to how that would be reported. And the resection R0, R1, R2. So this gives you a very clear background, and you can see how actually the focus is all on the cancer. Yes, you need to know about background adenomas or anything else, but you don't want to waste your time reporting and describing at length with lots of prose about the specimen and about all of the specific abnormalities in the entirety of the specimen, because ultimately the clinician is going to be interested in the cancer type and any background adenomas or specific abnormalities that could be related to the cancer. So you've got to, and certainly in my practice, I'm always trying to make my reports relevant to the clinician. Yes, I'd like to do detailed description about all of the pathology that I can see, but in reality, we have to think about the service users and the people who are going to use the report. What is the information that they really need to make them actually valuable to them? This is an example of the thyroid cytology data set, and the thyroid cytology has got detailed information about the Thigh classification, which is what we use in the UK. I know there's the Bethesda classification as well, but that's what we use in the UK. And actually what's really helpful here is that it gives you all the kind of specific situations where you might use a Thigh3A, so the atypia category for thyroid. And again, this is to make sure that the Thigh3A category is used in only the minority of cases, and making sure you're consistently allocating that case to a specific category rather than having everything dumped into an atypia category. And that was again part of the Paris classification for urine cytology, was again to try and avoid kind of excessive atypia calling and trying to focus to the idea of urine cytology, which is to exclude high grade malignancy. And so this again is about consistency, giving guidance about specific situations where you would use that category to make sure that everyone is reporting in a similar way. The other thing that is also quite common in data sets, which is really helpful, is immunohistochemistry guidance. And granted that you might not have all of these immunos available in your department or even your region, and that's fine. It's not to say you must use all of these immunos, and even I don't have a lot of these immunos in my department, but at least it gives you some guidance to say, okay, well, if I've got a medullary thyroid cancer, then I would expect this immunopanel profile. In breast, they've got a very nice table as well. Sorry, I'll come back to that. They've got a table about, again, practical immunohistochemistry to use to diagnose. So there's also some information about relevant molecular markers if it's applicable. So in the GUIDE data sets, there's more information about very specific mutations, which I know some of the new classifications are based on. So that's also there. But as it said, they may not be able to perform these further tests themselves, but just an awareness of them is important, because you need to know that you need to kind of have material available to have those tests done, should it be required. The microscopy section, this is the urology prostate reporting data set, and that has a nice diagrammatic representation about how the cause of prostate kind of correlate to the radical prostatectomy, and what the kind of grading pattern for percentage, etc., and how that represents. And so that can be really helpful. This also talks about seminal vesicle invasion, so radical prostatectomy, and how you'd interpret extraprostatic extension. The core microscopic items, again, it talks about, so there's a lot of things that you can include in prostate biopsy reporting, and some of it is extraneous, so this data set really kind of gives you the focus to say, okay, these are the things, these are the core items where there's a strong evidence base that these have prognostic value, and so that's what you should focus on in your reporting. This is the example of challenging situation in breast reporting. For example, when you have sclerosing adenosis and you're not sure if this is a small tubular cancer or is it colonization or cancerization by an in situ process, etc. So they give you some nice microscopy photos, not just for cancers, but also for benign entities as well. Obviously not for all data sets like that, but certainly some do have some nice microscopy photos of benign conditions as well to guide you. This is again the breast data set, which talks about practical aspects of measuring invasive tumor foci and whole tumor measurement, and what the distinction is, and what do you do if there's DCIS in between, what do you do if there's a satellite focus. And so all of these scenarios are really helpful, and I certainly refer to this quite commonly in my practice. It gives you practical guides about how to do your mitotic count for breast grading, so giving your field diameter, and there's guidance about how to calculate your field diameter as well, and then how to score the mitoses based on your specific microscope, again for consistency, which is the most important thing. This is a diagram about HER2 testing, so how you might do HER2 testing for breast cancer, and just talking about when you would do FISH, and that it's important to have validated assays and quality assurance. And there's a lot of detail in the breast data set about quality assurance on ERPR and particularly HER2 testing. So this is what I was talking about. So the immunohistochemistry in breast cancer diagnosis can be really helpful. This common scenario where are we sure that this is epithelial hyperplasia of usual type or atypical ductal hyperplasia or low-grade ECIS, one of those difficult challenges diagnostically, which we can use immunohistochemistry to help guide our practice. And lobular cancers, again, always a challenge. So so in summary, I hope I've conveyed to you how useful data sets are. I use them, in my daily practice. Really helpful, quick reference guides. You can use the pro formas as you want in terms of adapting them to your local departments. But then once you've done that, it really provides that great standard that you can audit against, and make sure that your department, all your colleagues are reporting the cancers to the same consistent standards. So that makes it much easier for the clinicians to then interpret your reports, but also to get all the bits of information that they need. And so, yes, it provides a really good roadmap to reporting cancer histopathology to consistent standards, which are all based on a strong evidence base. The authors are all leading national and international experts. They have practical experience and do useful discussion of difficult scenarios. And there's also a lot of information about quality assurance and audit recommendations, which are really helpful, as I've said. But importantly, you have a focused report on what's evidence-based with prognostic significance, but you also have the flexibility to include non-core data items according to local preference, if that's what you want to do. And the everyday application, as I said, quick reference, using it in cut-up, use the pro formas or adapted ones to save time and ensure consistency for data recording and your clinicians, for audit, using it for molecular to help guide what cases might need molecular testing. And there's a discussion about the WHO and AJCC classifications where relevant, and sometimes where there's slight differences between AJCC approach, for example, and the RCPath approach, and what the evidence is and why the RCPath have chosen to go down a particular route. So that's all really helpful as well. So in summary, I hope I've conveyed to you the information about what datasets are, what the elements of the datasets are, and hopefully I've emphasized to you that the datasets can be applied in daily practice, and they're really, really useful documents to use. And they're freely accessible, and I hope I've encouraged you to utilize them in your practice if you don't already. So that's just my last slide, just to emphasize what data sets are and what how useful they are and the real message behind them. I hope you found that helpful. I wish you well, and thank you for listening. Bye-bye.